Please join me in welcoming Ben.
Thanks for having me here, and I'm happy today to talk about medical cost trend with you all. This is actually a report and analysis that we've been doing for more than a decade now, and I think it does shed some light on what employers are experiencing, what consumers are experiencing. We dig into some of the inflators and deflators of trend. And when I go through this analysis, you'll see that we don't go through every potential inflator and deflator of trend. Each year we try to pick up on one or two of the more interesting emerging trends that are out there that are inflating and deflating our medical costs. And as Cheryl mentioned, I knew I would need to do this because everyone is interested, but I did slide in the back in the appendix a few other key points about what's happening post-election. And if we have some time and you all are interested, I'm happy to go through some of that as well. So first of all, why do we choose to look at an employer cost trend? One of the reasons is because employers actually insure more Americans than really in any other type of insurance that we have. Well, I should take that back. We're almost 50-50 now, but up until very recently, employers insured the majority of Americans, with the remaining being insured through Medicare, Medicaid, and some other types of programs. So understanding what's happening in the employer market is really the key to understanding where medical costs are going. And in fact, it's one of the reasons that each year before we release the report, we actually meet with the CMS Office of the Actuary and some of their actuaries and economists, and we trade information because they're interested in what we're seeing on the employer side, just as we're interested in seeing what they're doing and what they're seeing on the government side. To develop this report, it's based on a very long research process, which includes interviewing the chief actuaries of all the major national insurers, as well as several of the very large regional insurers. We also survey large employers, over 1,000 large employers across the United States, with our PwC Touchstone survey, and we're asking questions about trend in that survey. And then we also survey an association of provider-owned and smaller health plans, just to make sure that we have a lot of our bases covered. In addition to that, we look at Wall Street analyst reports and other publicly available information from CMS Office of the Actuary. And all of that information goes into our model each year as we make our projection of what medical cost trend will be in the coming year. Now, the first question a lot of people ask is, well, how do you define medical cost trend? What the numbers that we're about to see, what's going to be included in that? And it's really utilization times cost. So it's the cost of providing direct medical services each year to a person. What that trend level is. How much is it increasing each year? I can say how much does it increase each year because it always increases. We don't ever have to think about a decreasing trend. The trend may slow, but it's always positive. It is not a premium number, so the insurance premiums that you may see could be different and will often be different than the medical trend that I'm showing. Medical trend is often an input into the premium number, but premium can include a lot of other things like profit, administration, things of that nature, whereas our number really is just the cost of providing those medical services year to year. A very important number in, of course, putting together premiums. So let's take a look at, without further ado, let's take a look at what we are projecting for 2017, which is a trend rate of 6.5%. I think there's a couple of interesting things to think about with this chart I'm showing you here. One is these are our trend numbers for over the last decade, and if you'll look at 2007, you'll see that we were projecting a double-digit rate of increase. So almost a 12% trend rate. It's hard to believe. It wasn't that long ago. Those were the kind of medical trend numbers we were projecting. And if you look at over time, you can see that it has been slowing, and now we're actually at projecting 6.5 for the coming year. The other point around the chart that I would point you to is the fact that we're projecting essentially a flat growth rate from this year to next year. And I think that brings up the question, which is, have we run out of some of our tricks of bringing medical costs or slowing the growth of medical costs, and are we about to now turn around and start going on an uptick, or is this a lull? And we'll see this kind of flatten out for a few years, or are we going to double down on some of the things that have brought trend down and continue in future years the decline? So it's very much, you could put a question mark kind of at the end of this chart. Where do we go from here? We can look back and see that we've come a long way, and this is often counterintuitive to the rhetoric that we hear on political, out in the political campaigns or out in the media often, that healthcare costs are going up and they're out of control. And the answer to that is, well, yes, but if they're actually on the employer side, the growth trend is slowing. There's some good things that have been happening. Now, one would not necessarily want to pat themselves on the back and say we've won the war, because when trend is outpacing general economic inflation, it can cause a lot of problems. And I'll show you some of that data a little bit later. But let's put this in a historical context. So now we're really looking at national trend numbers. So this is growth in health expenditures for private employers going all the way back to 1961. So now we're looking at government data, not PwC data, but we did do some analysis on this to show the linear trend, just to smooth that curve out. If you looked at all of that data through the years, and you can see that on a national basis, total private employer spend has also been slowing over time. And there's been some, as one would expect, there's been some dips and valleys throughout, and it's one of the reasons why we have a question mark at the end of ours, because typically there's a cycle, and you can kind of see when you look at the yellow line there where we have the 4-year moving average, it helps to show those cycles. And you can see one in the early 90s when HMOs really came, or mid 90s when HMOs were really at their peak and they were bringing down medical costs. Well, you can see that we were at the bottom of the valley, and then HMOs lost a lot of their power as gatekeepers, and you can see it start to come back up. And it does bring the question in these later years as well, are we going to go back up, stay the same, or move down? The other component that I'd like to tease apart is, remember when I said that medical cost trend, as we measured, has two components. So there's a utilization component and a price component. And one of the hardest questions to answer is which of those components is really having the most effect on medical cost trend. So we took some publicly available data from the Bureau of Labor Statistics, and we teased apart the data set to try to show how those two pieces interact. And if you can see the lighter yellow trend line at the bottom, that's us teasing apart utilization. And utilization as a contributor to trend has been very close to zero over the last few years, and in fact has even moved into negative territory, whereas price has been fairly steady up there, 5-6% often. And I think what we can take from that is that when we've tried to address rising health costs, we have mainly done it on the side of utilization, and there's not been much work done in terms of bringing prices down. And I think this will make sense to a lot of you in this room, which is, where have we been trying to affect utilization? Mainly through the high deductible health plans, which have been implemented over the last decade. and those do have an effect on utilization. Our consumer surveys that we run with consumers each year show that consumers tell us we are forgoing care, we're not getting prescriptions filled, we are delaying surgeries, all of those things that I think you all have heard. This kind of bears it out in the data. So that brings up two interesting questions for those of us working on benefit design and things of that nature, which is, when are we going to address price? And that is the negotiation with providers and pharmaceutical companies and others, and then obviously not letting our eye off the ball on utilization. So let's talk a little bit now about where do we spend this money. So there's a lot of money being spent on healthcare. Which parts of the industry are getting that money, and where do we see those growth rates going in the next few years or the last decade? And there's a couple of kind of truths that we can take from this chart right here. One is that most of our healthcare spend is around the physician and inpatient hospital side. There is no doubt about that. And in fact, when we hear a lot of the kind of the inter-industry discussions around who's driving healthcare costs, insurance companies will say it's pharmaceutical companies say it's providers, so forth and so on. I think here's where we really see why people can look at costs in a very different vein. So it is true that most of that cost is on the physician and inpatient side, and in fact, as a proportion, pharmaceutical is a relatively smaller proportion, but it's the growth rate. If you look at pharmaceuticals over the course of 2007 to 17, so over this 10-year period, the growth rate is much higher than the other components. Even though it's, of course, part of that is it's starting from a much smaller base. The other component that's growing very quickly is outpatient. And frankly, that's by design. Most of our healthcare changes, policy changes, changes in benefits, changes in the way providers provide care, has been trying to move more care to an outpatient setting. And so it would make sense that that proportion is growing as well. Lastly, during our research this last year, we wanted to talk to employers and others about what's happening over in the ACA with the exchanges. And is there anything that employers can learn from the exchanges? So kind of take away politics or what's going to ultimately happen with the ACA. We now have had 3 years of the exchanges up and running. What is it that employers can see that's happening over there that they may want to think about or are thinking about? And so one of the things that we saw was this whole concept of exchanges. That's, we're so used to it now because we've been talking about it for the last few years. But the concept of the exchange, and certainly not just the exchanges in the state marketplaces from the ACA, but now private exchanges, and we're seeing some employers that have become interested in private exchanges. The other concept we've seen kind of being borrowed or thought about from the ACA exchanges are the concept of narrow networks. So a lot of the exchange plans that were being offered to consumers are more narrow networks. It's kind of the exact opposite of the way that most employer benefit plans have been built in the past, where they were really the broadest possible network. That's what employees like. They like to be able to go to any hospital in their city, any doctor, so forth and so on. But the exchanges had the insurance and the exchanges had a different take on it, which is one of the ways to decrease the premium is to have a much more narrow focus in terms of where consumers can go. And then the last piece I think that comes out of the ACA exchanges is this concept of cross-subsidization. So previous to the ACA, there was a lot of talk around employer health costs were as high as they were because you have to make up for the fact that there's a lot of uninsured. And that's what providers and insurers and others would often say. It's kind of like an airline where the business passengers are going to pay more than the recreational passengers. And so there's this kind of cross-subsidy happening. And I think we've heard a little bit less of that recently. And the question is, with more people insured in the United States, what will that do to employer costs? Will that start to ultimately help to slow costs as well? I think that's an unanswered question right now. So with that as a backdrop, so there's a lot of kind of macroeconomic data around trend and what we're seeing nationwide. Let's talk a little bit about what we think are going to be some of the more interesting inflators and deflators of trend this coming year. And one is around this concept of convenience having a cost. And so this is, in fact, both of our inflators this year were very interesting because they were both positive trends that we have talked about in the past, but we also have to be realistic that they can increase trend, especially over the short term. One of those is around convenience in the use of retail clinics. So although we have been very bullish on the use of retail clinics for employers because they provide great access, they typically have very positive outcomes, and consumers love them and employers love them. There is some cost associated, and you can see from some of our data here, we're looking at the total number of retail clinics. I mean, they've really exploded over the last few years. We've got over 3,000 clinics in the US, and more are being built every day, especially in high growth, high population growth states. So for where I am in Texas, every day there's a new retail health clinic opening up on each corner. I mean, it really is amazing the amount of access that's out there now. We can also look at the percentage of consumers that have gone to a retail clinic to seek care, and we project that this year that number will be at 40% will have gone to a retail clinic over the course of a year. And by the way, they're usually the consumer satisfaction for those clinics tends to be pretty high, mainly because of the easy access, longer hours, things of that nature. But over the short term, it can increase medical cost trend, and here's why. Because when you make access really easy, what happens? You really induce demand, and so we've seen this happen. And I kind of use just a little scenario where if you went back 10 years ago, before the days of retail clinics and a lot of this easy access, if you had an earache on Friday, most likely on Monday morning, you were going to call your doctor and make an appointment and try to get in and say, I've got an earache. If you have an earache on Friday now, you can, on Friday, when you leave work, go by a retail health clinic and get it checked out. But in that same scenario, what if previously when you had your earache and you were waiting till Monday to go call the doctor, that over the course of the weekend, it starts feeling better, so you never call the doctor. Or you call your doctor and you make an appointment, it's 5 days out, and by the time you get there, you cancel the appointment. So that's one of the scenarios where demand can actually increase when access is so easy. When there's very little barrier, people are going to use it more. We see the same thing on telehealth. Telehealth, generally a great thing. I talked to a very large employer when they implemented a telehealth option for their employees 2 years ago. They actually implemented it with no cost sharing. So they want to really increase primary care and access and have their employees be able to get things taken care of kind of at their desk and not leaving work, but they had no copay. And they saw, as you can imagine, utilization going through the roof, because then you have people sitting at their desk thinking, gosh, my throat's a little scratchy. Hey, I'll just call the doctor. This is great. And so what they did was the very next year they put in a copay. And so these are just two scenarios of how you can have something that's a good thing. A retail health clinic is one of the most cost-efficient options for a primary care visit, and it's very convenient. But if you don't have the right mechanisms in place, you can see increased utilization. And we think in 2017 it will be an inflator of trend. Kind of the same logic I'm going to show you here with mental health and behavioral health services. So this is another area where we have seen employers starting to increase spending. So now what we're looking at is the percentage, the share of total health spending between 2005 and 2013, and which share of that is going to mental health spending. And you can see that it started, really a very modest. We're talking about modest percentage of increase here, but they are increasing over time as more employers are putting more of their resources towards mental health costs for their employees. And again, here's another one where we're saying this is generally a good thing. Why would employers want to invest in behavioral health? Well, because behavioral health can be very costly for employers in terms of absenteeism, presenteeism, and also non-brain health is often affected by brain health. So someone who's suffering from depression may not be taking their medication for diabetes. Excuse me. So it becomes extremely important for employers to have these benefits available to their employees. And we're also seeing a lot of the stigma around brain health start to dissipate as people realize the brain is an organ like any other organ and should be treated as such. But it's not just goodwill that's making some of this happen. Mental health parity, there's a regulatory aspect to this which started way back in 2005 with the mental health, or 2008 with the Mental Health Parity Act. And that act was reconfirmed and built on through the ACA, and we've seen enforcement actions now by the attorneys general last year in both New York and California around mental health parity. So trying to enforce that kind of equality of access to services. And this is something that has been a challenge in this area for employees, is that there's essentially a shortage of mental health providers in the United States, and many of them who actually do not take insurance. So that is a common a challenge. Now, some of that we think will be solved through technology. So one interesting thing about mental health services is that one of the great ways to provide those services is through a telehealth option. People like the privacy of being able to talk to their provider in their own home or using their smartphone, and much of the provision of services is done through talk therapy, so it works very well through either a telehealth or some sort of virtual health visit. Let's go to the other side of the house. So we've talked about two inflators for 2017, both of them actually on the utilization side. So an uptick in utilization around retail and convenient health, an uptick in utilization around behavioral health. Long-term for employers, maybe not a bad thing, but still something to watch. On the deflator side, we're going to move to the price side of the house, which is, are we going to do anything about the price of services? And here we're looking at high performance networks, and we have some survey data from our over 1,000 large U.S. employers that we survey each year. And these high performance networks, so these are provider networks where the providers have agreed to meet certain quality standards and efficiency standards. And by definition, almost all of them are narrow in nature. So not every provider in the community is going to agree to these standards, and so they are narrow in nature. So we're starting with a pretty small percentage of employers who are saying we've already implemented one of these high performance networks. So in 2014, 3% of employers said they had. That doubled to 6% in 2015. And then this year it was up to 9% had. And then we also asked our employers, but are you considering it? Maybe you don't have it yet, but is this something that you're considering? Is it on the table? And we can see a much higher percentage is there. In 2016, 43% of our employers said they were interested in implementing a high performance network. Now, I want to bring everyone's attention to these percentages, because if you went back a decade ago and this same survey question was asked, which we've asked, around high deductible health plans, you would see a very similar percentage and growth rate. So, it wasn't but 10 years ago that many people looked at high deductibles as a niche offering. This is something that was not going to be popular, that only a few employers would adopt and only a few employees would adopt. And we're at a very different place right now in terms of benefit plans. And I think we're going to see the same thing on this high performance, more narrow network side, is that this is really the first major widespread attempt to really work on the pricing side, not just utilization. Utilization is what high deductible deals with, but really the price negotiation, the contract negotiation with providers are what these more narrow networks deal with. So we expect to see these growing over time and the interest growing with them over time. The challenge is, and it's the same challenge that everyone faced, or those of you that may have a high deductible face with your employees, is that employees, if they don't know what they're getting into, can have a very, very bad experience. And we know this because people often buy on the premium number, and then when they get to services, then they find out they have a $5,000 deductible, and they are apoplectic. They're completely surprised. They didn't understand. And these narrow networks, we could again have a repeat of the same issue. Do people know what they're getting into? That not every hospital in your town is going to be in this by definition. That if you're switching over from another plan, that you need to have a list of your physicians and see which ones are going to be on this, which ones are not. And in the areas that we've seen them being implemented, of course, those are some of the challenges. Some employees love it because it's keeping their premium lower, and then others have been, quite surprised when their favorite pediatrician wasn't in the network.
So I have a question about that point about high performance networks and narrow networks. Mm-hmm. The Alliance has been in this area for decades, studying cost and quality with an eye toward how do we move the market to the best value. And this is a tricky proposition because in our experience looking at cost and quality data, we don't see one system that is the best at everything. The high performer for cardiac care is different than the high performer for ortho, and neither may be where you want to have a baby. And what we also know is that there is variation that impacts patient care within physicians in those high-performing hospitals and medical groups. The model, the prevailing model in the market is narrow or high performance means a system. It's this system, but not that system. But we know that there is meaningful variation in value within each system. So do you have some guidance about how to address the reality that we know not one system is the best at everything with this trend toward narrowing networks?
Yeah, I think that's a great point. So one thing I would say is this is a much easier proposition in the larger area you're in with has multiple health systems. I mean, this gets more and more difficult. I mean, this especially gets difficult when you're in a metropolitan area where there's maybe only one academic medical center that can do tertiary, quaternary care. There's really no choice. And so that's the first thing I would say, is that I think that you're going to see this take off more in some of the bigger areas where there's a lot of different choices already of provider systems, multiple systems. So that's the first thing. I think the second thing which is absolutely spot on, which is it's hard to say overall one system is best at everything. And so I think this is where the dialogue has to start between the employers and the providers. which is, if we're going to start building these, and obviously the payers need to be a part of this too, but if you're going to start building these networks, how are we going to give those providers, feedback in terms of who we are going to use and who we want to use? And I would say I think it's okay to give them a seat at the table, and to have some transparency around what you're happy with and what you're not happy with. I mean, wouldn't you do that with any other supplier that you're working with? I mean, let's just make up an easy one, like, office supplies or something, where you're really, really happy about all the paper you're getting from them. I don't know why I use that example, maybe because I've been watching reruns of The Office with Dunder Mifflin. But anyway, you're very happy about the paper you're getting from them, but you're extremely unhappy about, the technology piece of the computers and stuff that you're buying from them and the printers. You would give them that feedback. We want to keep you, but if you don't improve these things, how can you be a preferred provider for us? And I don't know why we don't do things like that more in healthcare, is have that dialogue with the providers as well. And I think it especially becomes even more important when you have fewer choices in your community of the different providers to work with. And then I think there's a third piece out there, which is, frankly, there are some companies where, and companies and employees, where cost is the most important thing. It's even more important than quality in some ways. I talked to an employer just a few weeks ago that most of their employees are very low wage. They're very low wage workers. They're in the service industry. And what they do for their employees is they have a few on-site clinics in the major cities. And if they go to that on-site clinic, it's free for their employees. It's a huge hassle for many employers. Their employees would be very angry to tell you have to tell, I have to drive across town to go to that, the clinic that you've chosen for me. But what the head of benefits said is, these are very low wage employees. If driving across town for something that's free, they're more than happy to do that. And so I think that's part of it as well, is that every employer has kind of a different employee need. And some are going to be very, very interested in quality. Some are going to be more interested in cost. A lot are going to be interested in both. And certainly no one is interested in actual poor quality. So that's kind of the third bucket, I think, to think about as we're thinking about more narrow networks. The other piece around cost are prescription drugs, and especially specialty drugs, and that's been on payers' radar screen and employers' radar screen for the last couple of years. And one of the things that we see as a deflator, though, for this next year are PBM's ability to win price concessions, negotiations, and we think that they've learned a lot over the last couple of years from the Hep C drug examples, which were very, very high cost specialty drugs. And so this is an example that we're putting out here, but it's really an example that's based on reality, which is if you take a drug, a first to market specialty drug, that's, let's say, $60,000 for a prescription. There are several specialty drugs where that is well within their price range. That the PBM may get, if they're the only drug on the market, they may get a discount of 5%. And so you're looking at a drug that's $57,000 for a course of therapy. As soon as a competitor drug comes out, we have seen examples of those discounts being immediately 40%. So you kind of go from an overnight of the drug costing you $57,000 to the next day it's costing you $36,000. It's a huge price concession, and that comes from competition. And that's really the key in a lot of these specialty drug costs, is when there's competition, the price goes down. And PBMs are getting more sophisticated in terms of their negotiating. So now we're looking at PBMs. So maybe there's not a second drug on the market yet, but there's a second drug that's coming, and it's going to be on the market in 6 months or 9 months or a year. And so you can still potentially use that as leverage. Pharmaceutical companies may want to work with a PBM to keep them as a customer, to keep their drug on the formulary, and to offer a better discount up front, knowing that there's going to be competition coming later, and they may have to offer even a deeper discount later. So let's look through now something a little bit more real. So now we're looking at the hepatitis C therapies, and we've been tracking these since 2014. And actually, the major amount of cost around these hepatitis C therapies we've passed them now. And so 2017, we're actually looking at them not being a contributor to trend as they were in the past. There was something very unique about the hepatitis C therapies in that they were both a high cost specialty drug, and also there was, at least in the beginning, a large population that needed the drug. And and this was not just, these new treatments were not just a Me Too or something like that. I mean, these are treatments that in some parts of the population have actually they're considered medically cured of hepatitis C. There is no hepatitis C seen in the body after treatment. So it's a very this is a very positive step in terms of hepatitis C treatments. And the numbers that you're seeing here, these are for employers, so you can see the thousands of patients being treated in 2014, which is our orange line. The red line up at the trend line up at the top is the change in medical cost trend. I know you may not be able to see the color. So the top one is the change in medical costs. That orange line is the annual number of patients treated, which basically peaked in 2016 and is now going to start declining. And the reason that happens is because if you think about it, the hepatitis C treatments had to treat a whole backlog. People who got hepatitis C in the 1970s and 80s, and until they changed the way that our blood system was protected, we had this kind of cohort of people who had gotten hepatitis C, mainly, if you're an employer population, mainly from a transfusion. These are not IV drug users typically. In the employer population, these are people who've had transfusions back in the 70s, and they have hepatitis C. So it's a cohort, it's a population. And once you start treating that population and people move into a cured phase, you don't have the numbers replacing them. And that's why we're actually seeing the employer population of those with hepatitis C decrease, and then with it, the medical cost trend attributable to it decrease as well. But if you go back to 2014, this was a very big problem. We're looking at the contribution to trend of almost 700 basis points into trend. I mean, that's a huge part of the medical cost trend, and that is why we saw actuaries, very, very concerned when this came on. And the concern was, what if there are more drugs like this? I mean, there's hundreds of specialty drugs in the pipeline, and this was just one class of drugs that did that. Well, here's why we think that was an anomaly, and we won't see something like that necessarily happen very often, because it has to be both a high cost and a high volume drug to have a very noticeable effect on trend. And you can see in the left-hand bar, that's an example of what those hepatitis C drugs did to trend. If it's a low-cost, high-volume drug or a high-cost, low-volume drug, very little effect on trend over time. One of the drug classes that was talked about after hepatitis C was the PCSK9 inhibitors, and those were supposed to be the next ones that were really going to take off and increase trend. And that actually did not pan out. A lot of those drugs were injectables, and so consumers don't like taking injections, and so they would rather stay on their current medications than switch to those newer drugs, and so we didn't see them take off. Now, it doesn't mean there's plenty in the pipeline. We just don't see something this next year that would be to those levels. So just a few kind of key points to wrap up trend, and I'll mainly focus on employers here. What do employers need to do over this next year, or at least the next couple of years? So one thing that we talked about is really thinking about cost sharing in terms of ambulatory services. So keeping in mind there's some good things out there in terms of increasing access, but you also want to monitor that access and make sure the utilization is, for the right reason. I always give the example, because it's an easy example, of a telehealth option with no copay. You are going to, you're going to really induce demand, but are you getting a lot from that if people aren't even thinking about whether they really need it or not? The second point is considering a high performance network, and I think we've already talked a little bit about, this is not something that's easy. We think this is something that's going to be, it's going to be like high deductible health plans. It's going to be something that happens over the course of a decade. And something I failed to mention when I was answering the question before was, we also think that most of these are going to be just plan options for employees. This is, people are not going to put in a high deductible health plan as the only plan option for their employees. So that's one thing, is always to keep things as a choice in the beginning so people get used to it and understand it more. And I think the third big piece, of course, are the PBM arrangements and making sure you're getting the value that you want to see from PBMs, and knowing that competition becomes very, very important in terms of managing drug prices. And we've seen this, it's popped up in the media with some very egregious stories of, now we have some investment companies coming in purposely trying to buy drugs that have been on the market for years and years and years, but now are only manufactured by one company, and then they're able to raise the price as much as they want. And I think that further kind of makes our point that competition is extremely important. And then you can see here, I've got some other key points around what other parts of the health industry are going to be doing over the next year. I've got 10 minutes, so let's go into the Trump transition, and I can talk a little bit about what we're seeing here from our analysis there. So the election, obviously, a huge surprise, I think, for many in the health industry as well as the U.S. in general. And what we did is prior to the election, we first of all, just to back up a little bit, so this is based off of a report that we published the day after the election. And the way that we do that, HRI, for the past 12 years, we do a presidential health plan analysis, and we write essentially 2 reports, one for each candidate, that we work on all the way up until the point of the election. Then the election happens, and obviously we release the report of who won. And so it's kind of fun, but I can always go back, and now I'll have my Clinton health plan on my hard drive. I have my Al Gore health plan. I've got my John McCain health plan. So if any of these people come back, I already have their health plan analysis ready to go. So we have the Trump analysis, and there was really kind of two major buckets of change that he was looking at. One is this around repeal and replace, and we'll get into kind of what does that all mean. And the other bucket of health change, what I would call a little bit more of the traditional Republican health policy changes. So those are things that actually John McCain talked about. George W. Bush, when he was in office, started the health savings account. So these are what I call, very kind of traditional Republican platforms around health savings accounts, cross-state selling of insurance, allowing converting Medicaid to block grants, and then even allowing individuals to deduct their health insurance premiums. That was something that John McCain talked about as well, so that it wouldn't be just employers who get the deduction, but also individuals buying insurance on the market would get a tax deduction. There were some other things that Trump added in that were a little bit different than what one would consider the traditional Republican policy offerings, and those are around pharmaceutical negotiations. He talked some on the campaign trail about allowing Medicare to negotiate, allowing reimportation of drugs, and even just very recently, we heard him talk about the high cost of drugs, and pharmaceutical companies definitely sat up and take notice. After the election, some of these platforms that were talked about and on the website were actually taken down, and so that's why I mean there's a little bit of a moving target. I think some of that is as you're kind of transitioning and moving in, you're now starting to hear a little bit from industry, and so we saw the reimportation issue come down, and a few others like that. So let's dig into it just a little bit. But that's a very high level, kind of two buckets of work that he talked about: repeal and replace the ACA, and then some of this kind of traditional platform of free market mechanisms that could be implemented. Since then, we've had a little bit more detail, so we know that there is going to be a focus on expanding health savings accounts, and the details around that, are around being able to put more money in them, being able to spend the money on a wider variety of things, maybe like over-the-counter drugs and things of that nature. Purchasing insurance across state lines is still definitely being talked about. High risk pools. So this is the big question on repeal and replace, which is how do we replace the 20 million? Where do they get insurance? Those that are insured now. And one of the issues around that is implementing the state high risk pools again. And of course that brings up the same questions we had when those concepts were around before, which is it all comes down to the funding. Many of those state high-risk pools were not able to cover all of the people that needed coverage that had pre-existing conditions. And then reforming FDA, which some of that has already really been done with the 21st Century Cures Act, which is supposed to be signed by President Obama today. And so that has some modernization around the FDA. It was a bipartisan supported bill. And then modernizing Medicare, and we're hearing that being talked about as well. Here's some things that are not being talked about very often, and we certainly didn't see these in the campaign. So here what we're doing is we're looking at healthcare spending really crowding out discretionary spending. And so we think any backdrop of health care change or further change is going to require a focus on health costs. So it takes us right back to what we were talking about with behind the numbers just now on medical cost trend. And that is, even though on the employer side we've seen it slow, it's still outpacing inflation by 2x, 3x times. And what that means is that Congress has fewer and fewer discretionary dollars to spend. So essentially, healthcare, Medicaid, Medicare programs, Social Security as well, all these entitlements where the costs are growing faster than general inflation, they crowd out things like spending on higher education, parks, transportation, things of that nature. And so it becomes a point of more pressure on reducing those costs. And so the question I think for the healthcare industry is, how will that happen? Is that going to be something like going back to what happened in the BBA or BBARA, where they actually just cut Medicare reimbursement, and so doctors and hospitals kind of bear the brunt of that? Where exactly do those savings come from? Is it going to be from taxes? I mean, that's the way the ACA was funded, was half through new taxes and half through reimbursement cuts. And that's what allowed to redirect that money for 20 million people to have insurance. So those are, we think, some key macroeconomic questions are going to have to be answered over the next year. The other is, where do these people now get insurance? And we've just heard, and you're right on the cusp of this, just in the last week, we have now heard from the AHA and AHIP and pharma, all of the major health industry associations are now saying, hold on, we need an orderly transition. We cannot move 20 million people into an uninsured category. And frankly, a lot of them are, if you kind of read between the lines, are saying, if you're going to replace the ACA, it better be pretty similar in the sense of it needs to cover at least those 20 million people. And there's an interest in that for the health industry. If we look at Wall Street analyst reports on insurance companies and pharma companies and big health systems over the last few years, they've done relatively well because the U.S. government has been subsidizing a very unaffordable product for Americans, health insurance. And now, now our large health systems are seeing their bad debt has decreased because they've got more people who are insured that they're seeing. Pharmaceutical companies like insured people because they can buy drugs. Health insurance companies like insured people because that's their customer. So there's a lot, now we're starting to see the industry really insert themselves. We didn't see that as much before the election. And frankly, there was a lot of, because it was political, there was a lot of, disinformation out there. For example, all of the data that I'm giving you all about what's happening to employer medical cost trend, that's not affected by the ACA. The ACA can't take credit for the fact that the medical cost trend has been slowing, nor can they be blamed for employers' premium increases, especially large employers, which have had very little effect from the ACA. So the ACA, in some ways, was very neutral towards employers, with the exception of small employers who have to absorb a lot of the administrative costs of implementing a new program. But for a large employer like my own, like PwC, we provided insurance before the ACA, we provided insurance after the ACA. We have a benefits department. They make sure the right paperwork is done, and that is that. And that's the same for about 96% of U.S. Businesses. Very different story, though, for the individuals who are on these exchange. Where are they going to get covered, and what's going to happen with small employers who often still find it challenging. Oh, gosh. Okay, sorry. The graphics got messed up on this a little bit. Really the point here is that now we're starting to see the reality of politics, right? The election is done, and the inauguration is January 20th. And now we see that President-elect Trump is going to have to work within a constellation of other groups that have power. The Supreme Court, the Congress, thin margins in the Senate side between Democrats and Republicans. There's no veto-proof majority there, and so there's going to have to be some cooperation. Consumers are going to have a voice in this. Agencies, so federal agencies, if you look at HHS, which employs thousands and thousands of people, there's a little bit over 100 political appointees at HHS. So when President-elect Trump comes into office, that's the mark he will be able to make on HHS, is they will have over 100 new employees at HHS that are political employees. But there's thousands of employees that are still going to be there that work in that machine. In the agencies, it's not so easy to change on a dime how these large agencies like CMS and others maneuver. And of course, the associations and advocacy groups, although we made this slide a month ago, we're starting to see them come out now and talk about these issues around the ACA. The other group, of course, are consumers, and even though consumers didn't talk, there wasn't a lot of talk during the campaigns around healthcare. In fact, it was often not a part of the debates or a lot of the campaign speeches in terms of any detail. We know that consumers are interested in the issue because we've from our surveys, you can see that 79% say their number one issue is the economy. Right after that, we see healthcare and national security tied. I think most people would be surprised to see healthcare polling up there with national security, but it does. And then we can see what their priorities are: wanting insurance to be more affordable, lowering healthcare costs being a priority. So they're very focused on their pocketbooks. around that. And then again, I think from a consumer point of view, this brings up the question of how do you insure people if you're not going to insure them through the exchange or an expansion of Medicaid? Do we change our definition of insurance? And that was one thing that was done by the ACA. Prior to the ACA, if you were a large employer and maybe in the service industry, some of the insurance benefits that you added would not meet muster under the ACA, right? They were often considered like skinny benefits, or they had a lifetime limit, things like that. And so will we go back to having some of those type of plans to make insurance more affordable? We're starting to see the appointees come out. I know everyone has seen and heard that Representative Tom Price is the nominee for HHS Secretary. I think the two important things to remember from Mr. Price. One is he's been a vocal critic of the ACA and has been for a long time, but the other is he's actually a specialist, a physician, an orthopedic surgeon. And so I think for doctors, they're looking at this as maybe an opportunity to have an advocate in that position that really understands what they're going through in terms of compliance with technology requirements, compliance with reporting. And so I think that's where we could see potentially a lot of influence from Representative Price in that HHS role. What will happen to all of the kind of the quality reporting metrics and things that have been implemented under Medicare and the CMMI, which is the CMS organization that does all of the new, all these new payment plan, ACOs and things of that nature. CMS Administrator, Seema Verma. Two important things to think about from her is, one, she comes from a consulting background, so a business background, and the second is the architect of these flexible Medicaid plans, different types of Medicaid plans that Republicans are very interested in. They're talking about block granting Medicaid. They're talking about the Republican governors who have implemented the Medicaid expansion under the ACA. They've all asked, and many have received, more flexibility around their Medicaid program. Either they're implemented by private plans, Medicaid managed care plans, or maybe they've had a cost-sharing mechanism. That is something that's been on the Republican Party platform for a long time, that people who receive Medicaid should have more skin in the game. So maybe there's a work requirement, there are copay requirements, some sort of health savings account requirement. So those are the type of things I think we're going to see a lot of around the country, or discussions around implementing Medicaid.